This recorded lecture will be going over Chapter 8, Care of Patients with Cancer, in the Med-Surg textbook. Cancer is the term given to a collection of related diseases that are characterized by uncontrolled abnormal cell growth and spread into the surrounding tissues. Cancer is considered a chronic disease that can worsen and improve again over a course of a patient's life. The prostate, breast, lung, and bronchus, colon, and rectum are the leading sites for new cancer and cancer deaths. The current incidence of all cancers is about 20% higher in each racial or ethnic population of men. Cancer death rates have been declining since the 1990s, with the combined death rate for men and women dropping by 25% from 1991 to 2014. Lung cancer remains the leading cause of cancer mortality or death among men, followed by colorectal and prostate cancers. Among women, lung, breast, and colorectal cancers are the leading cause of cancer deaths. Normal growth of cells and tissues occurs during infancy and childhood. Once adulthood is reached, most of the body's normal cells grow and reproduce only through mitosis. This is done to replace damaged or dead cells following any illness or injury. Apoptosis is programmed cell death, and normal cells, whenever damaged or diseased, will undergo this process. An abnormal replication of cells will result in a neoplasm. This is a new growth of a benign or cancerous tissue or tumor. Cancer cells do not behave like normal cells. Cancer development begins when there's damage to the genes of a normal cell. This leads to continuous cell division. Cancer cells are called malignant cells because damage to the cell's DNA will cause the cells to reproduce in an uncontrolled way and then invade other tissues and organs. Malignant cells do not seem to know when to stop multiplying. These cancer cells will continuously multiply, growing on top of each other and forming a mass or tumor. They will continue to grow and expand locally. Then they can break off and travel through the bloodstream or the lymph tissue in order to get to other parts of the body. This process is called metastasis. Cancer cells' demand for nutrients will deplete the supply of nourishment that is available for normal cells. The gene damage that led to cancer in the first place will take on new damage or mutations that will allow cancer cells to avoid apoptosis. Malignant cells can also be transplanted directly from one organ to another organ during surgery, when gloves and instruments can serve as vehicles for the transportation of the malignant cells. Another way in which malignant cells can contaminate normal tissues is by entering a body cavity and then coming in contact with a healthy organ. The prognosis for a patient with a malignancy will depend on how much of the malignant cells have attacked body tissues. Cancer that remains confined to the original site, or in situ, has not yet been released to cells. Even though the growth may have invaded the underlying tissues, it is much more easily to be removed and cured at this stage. A regional malignancy is one in which cells from the original malignancy have spread to the tissues around the tumor, such as nearby lymph nodes. However, if the regional cancer is not treated or is inadequately treated, malignant cells can continue to grow and multiply, eventually breaking away and then metastasizing throughout the rest of the body. This creates an advanced cancer that is most often fatal. Not all malignant cells metastasize, but most do. Patients with cancer will often die from metastatic disease, as cancer invades the major organs and disrupts normal cellular processes. And this picture can be seen on page 149 in figure 8.2. All cancer results from defects in the DNA of genes. These defects can be inherited or caused by mutations. Often genetic mutations will arise spontaneously for reasons that are unknown. Cancer-causing genes are known as oncogenes. An oncogene is a normal gene involved in cell growth and reproduction that then becomes mutated and predisposes the cell to become cancerous. Activated oncogenes will cause the cell to survive and expand instead of dying, and this ultimately results in a tumor or mass. Tumor suppressor genes are healthy, normal genes that slow cell division, make cell repairs, and tell cells when it's time to die. Each person's body has a different ability to withstand the effects of cancer-causing substances. These are known as carcinogens. We do this to mount a healthy immune response and to repair our DNA. Among these harmful agents, there are certain chemicals, sources of radiation, viruses, and other infectious agents. The individual's immune system response, certain hormones, and several inherited genes, as well as medical conditions, are thought to play a role in the development and progression of cancer. Although cancer can strike at any age, older adults are more likely to develop cancer. Immunocompetence is the capability of one's own immune system to deal with foreign cells. This would include bacterial, viral, or malignant. This does decrease with age, and it is an important factor in the development of cancers. As a result of this, age is the single biggest risk factor for developing cancer. Almost 500 different chemical carcinogens have been identified. Many of the cancer-producing substances in the environment are related to occupations that involve repeated exposure to these substances through handling or inhalation. Petrofluorocarbons and some pesticides are known carcinogens. Exposure to chemicals can decrease a person's immunocompetence. Cigarette smoking is a known direct cause of cancer of the lung, and it is believed to be linked to esophageal, pancreatic, bladder, kidney, liver, and colon cancers. Substances linked to the development of lung cancer include asbestos, radon, and chemical waste from industries. Suppressing the immune system's normal response can result in the ability of cancer cells to evade the immune system's surveillance and in cancer. Some hormones have also been linked to the growth and progression of cancer. Synthetic estrogens are linked to a higher incidence of breast and endometrial cancer. The use of exogenous or external hormones for the treatment of symptoms of menopause, such as night sweats or hot flashes, has also been linked to breast cancer. However, long-term hormone replacement therapy is associated with an increased risk of breast cancer after 5 years of treatment. Some substances are thought to be involved in the promotion of cancer. Promoters are substances that are not carcinogenic by themselves, but when combined with a known carcinogen, can lead to cancer development at a faster rate. Alcohol is an example of a promoter. Cancer occurs at a faster rate in those who are heavy consumers of alcohol and those who use nicotine compared to those who use nicotine but do not drink alcohol. In this manner, alcohol is considered a promoter that is also a co-carcinogen. The relationship of intense and prolonged exposure to radiation and the development of cancer was first discovered when a high incidence of leukemia occurred among people who pioneered studies of X-rays working with radium or uranium. In addition to leukemia, cancers of the skin, bone marrow, breast, lung, and thyroid are all believed to be closely linked to exposure to radiation. The ultraviolet rays of the sun can produce skin cancer. The most common types of skin cancer include basal and squamous cell cancers. These can be found in areas of the body exposed to sun and are related to the amount of lifetime sun exposure. People with a fair complexion have less protective pigment and are therefore more likely to develop skin cancer from UV rays than are people with darker skin. Severe sunburns before the age of 18 can also lead to a more serious type of skin cancer called malignant melanoma later in life. Radon gas is a colorless and odorless gas found within the decay of radioactive materials in rocks and soil. When inhaled, these radioactive particles can damage cells that line the lung. Viruses are capable of introducing new genetic material into a normal cell and transforming it into a malignant one. Viruses have their own oncogenes, which when activated can reproduce and transform into malignant cells. In fact, at least 10 cancers have been identified as being driven by a virus. These viruses are known as oncoviruses because of their ability to cause cancer. Viruses such as the HIV virus can damage the immune system and indirectly cause cancer by allowing oncogenes to be expressed. This leads to malignant transformation. People infected with H. pylori have a 10 to 20% chance of developing a gastric ulcer and a 1 to 2% chance of developing gastric cancer. Most cancers are caused by genes that are damaged or mutated throughout the lifetime and not inherited. Genetic markers have been identified for colon cancer, prostate cancer, pancreatic cancer, and leukemia. However, only 5 to 10% of cancers are related to a directly inherited gene. Breast cancer is more likely to occur in women who have a close female relative who developed breast cancer before the age of 50. When the breast cancer tumor suppressor genes BRCA1 and BRCA2 are inherited, this increases a woman's risk for breast cancer, but other factors can also determine whether or not a woman will actually develop that breast cancer. Take a look on page 153 in the blue cultural considerations box. Some populations are at a higher risk for certain types of cancer. For example, the 4 types of melanoma. African Americans are most susceptible to the acroleukinogenous type, whereas whites are least susceptible to it. Lentigo maligna melanoma is found most often in Hawaii. With the completion of the Human Genome Project, scientists are continuing to work on identifying genes that are related to specific cancers. Age, sex, and race are considered predisposing factors for certain types of cancer. The risk for all cancers increases with age. Approximately 76% of cancers occur in people aged 55 years and older. Although some differences in cancer can be related to hormonal differences between males and females, it is thought that most differences in cancer incidence between the sexes will result from health behaviors rather than actual gender differences. At present, 15 to 20% of all cancer deaths in the United States are associated with obesity. Obesity is also associated with a 30% increase in breast cancer risk. There is evidence to suggest that diets high in fats, red meat, and processed meats, as well as low in fruits and vegetables, are related to the development of cancer, specifically breast, colorectal, and pancreatic cancers. A diet high in fat has been linked to the risk of cancer recurrence, whereas a diet high in fruit intake is associated with fewer cancer relapses. There are now even studies linking type 2 diabetes to the development of several cancers, including breast, prostate, pancreatic, esophageal, and colon cancers. Common cancer-promoting factors would include obesity, insulin resistance, and inflammation in patients with type 2 diabetes. Tumors are often classified according to the organs or tissues from which they have originated. Malignant growths are divided into 4 main types. A sarcoma arises from mesenchymal tissues, such as from bone, muscles, and other connective tissues. A carcinoma originates in the epithelial tissues, such as the lining of organs or the skin. These kinds of cancers make up most solid tumor cancers of the liver, kidney, breast, uterus, lungs, and tongue. Leukemia and lymphoma are cancers of the blood-forming system. Malignancy of the pigment cells of the skin is called melanoma. One system that identifies cancers by how much the cancer or malignancy has spread is the TNM staging system. The 3 basic parts are T for primary tumor, N for regional nodes, and M for metastasis. The number written beside each letter would indicate how much the malignancy has spread and attacked other tissues. For example, T1N0M0 would mean that the tumor is small and localized. A label of T1N2M1 would indicate a small tumor with moderate regional involvement that has metastasized to one distant site or organ. Each patient encounter is a time that you can use to teach patients the following cancer prevention measures. We need to encourage maintenance of a normal weight. Encourage a healthy diet. We can do this by limiting the intake of red meats and processed meats, including hot dogs, bacon, sausage, lunch meats like bologna, and processed chicken nuggets. We should encourage the intake of whole grains, vegetables, and fruits. And avoid drinking excessive amounts of alcohol. Also limit your salted, grilled, and smoked foods. We need to encourage exercise. For adults, they should be encouraged to get at least 150 minutes of moderate intensity activity or 75 minutes of vigorous intensity activity every week. This can be spread throughout the week. Children and teens need to get at least 1 hour of moderate or vigorous intensity activity every day, and they should have performed some vigorous activity at least 3 days of the week. It is also important to limit sedentary behavior, such as sitting or watching TV. Because groundwater is often contaminated with chemicals from fertilizers, pesticides, and industrial waste, it is wise to know the chemical makeup of your local water supply. Check out page 155 in the blue patient teaching box. It's very important to use a broad spectrum sunscreen. This will protect against UVA and UVB rays. We may want to make sure that it has a sun protection factor or SPF of 30 or higher, and it should also be water resistant. We should educate our patients to wear protective clothing and sunglasses when outdoors to avoid sunburns, tanning salons, and sun lamps. This will greatly decrease their incidence of skin cancer. Instead of going to a tanning bed, we can encourage patients to use spray-on tanning solution. On page 155 in the green health promotion box, we can also see some warning signs of cancer. One widely used technology to detect cancer is to examine cells under a microscope and determine whether they are malignant or pre-malignant. This technique is called cytology, and the most widely used cytology test is the Pap smear to detect cervical cancer. A cytologic examination can be performed by obtaining a sample of secretions containing cells that have been released from adjacent tissues. If suspicious cells are found, the patient is then referred to a healthcare professional for more extensive diagnostic tests. Another screening technique used for colorectal cancer is the simple test for occult blood in the stool. Occult blood in the stool is not always an indication of cancer of the bowel or rectum. Other conditions, including colitis, can also produce the same symptom. Other procedures used to identify lesions that are possibly malignant would include radiologic studies such as X-rays or mammography, endoscopy, sonography, MRI, CT, clinical laboratory testing, and studies specific to the system in which the cancer is suspected. A biopsy of a tumor and examination of the cells obtained are required to firmly establish a diagnosis of malignancy in most neoplasms. A biopsy is the removal of living cells for the purpose of examining them under a microscope. The cells may be removed by surgical excision, which means cutting out, of a small part of the tumor, by aspiration or suction of cells through a needle introduced to the small growth, or by a brush biopsy. X-ray films should be the first step in examining the body for cancer. X-rays can be helpful in visualizing bone and hollow organ tumors. Mammography is a radiologic examination of the breast that is useful in diagnosing malignant growths or suspicious lesions that cannot be felt on examination. Another radiologic technique involves the use of a radioactive substance, such as a radionuclide or isotope, that is given to the patient before the X-ray filming. The isotope is a tumor-seeking chemical that searches for the tumor and can concentrate around it. If the substance is concentrated in a in a tumor, the growth will show up as a hotspot on the screen of the scanning apparatus. A commonly used radiologic scanning technique is the CT, or computed tomography scan. This method is non-invasive and involves relatively small amounts of radiation exposure for the patient. Positron emission tomography, or PET scans, is a nuclear imaging technique that will produce a 3D image of tracers within the body. Another imaging technique is called MRI. As in CT, MRI will produce various views or slices of the tissue. MRI is very accurate in allowing the radiologist to see tumors and abnormalities that other techniques may miss. It is currently used as a breast screening tool, in addition to mammography, only for patients at a higher risk of breast cancer based on their family history. Patients with pacemakers or certain metal fragments, clips, or shrapnel in their body cannot use an MRI. Due to the powerful magnets used in this technique, they can bend and twist metal and cause further damage within the body. An endoscope is an instrument used for direct visualization of internal body parts. During an endoscopy, not only can the tumor or suspicious area be seen, but a sample of cells can be taken to be examined more precisely under a microscope. No single blood test can establish a definite diagnosis of cancer, but certain tests are used to obtain specific information. On page 160, look at box 8.1, the prostate-specific antigen PSA test. It's important not to perform that test until after a urinary tract infection has been cleared. But this is an example of one of the tests that you can use to help aid in the diagnosis of cancer. Specialized tests for tumor markers have been developed. These tests will detect biochemical substances that are synthesized and released into the bloodstream by tumor cells. Tumor markers are used not to confirm cancer, but mainly to determine the response to therapy or detect a relapse. The first step is to find out whether the patient knows of their cancer diagnosis. You will then need to assess what the patient and family know about their illness and treatment plan. One of your responsibilities is to assess how the disease is affecting the patient's body, their quality of life, employment, and their activities of daily living. A thorough assessment of the patient's symptoms and a good general physical assessment of the specific body area affected by the cancer can provide a baseline for evaluation of changes in physical function caused by the cancer. A psychosocial assessment of the patient and family or significant others will provide data that can indicate psychosocial needs. Often the patient and family will require teaching about the cancer disease process and treatment. The healthcare team will work directly with the patient and family, and typically an oncology case manager will help coordinate the plan of care for the patient. Assessment for signs of disease or treatment complications, side effects of therapy, nutritional status, and pain and emotional distress should be conducted at every visit with the patient. There are 3 traditional modes of therapy for malignancies: surgery, radiation, and chemotherapy. Each mode of treatment can be used individually or in combination with one or more of the other methods available. The methods of treatment are chosen after consideration of the scientific information to support the treatment, the patient's goals, the patient's past medical history and physical condition, as well as the expected side effects of the treatments planned. Surgery can be performed for a variety of reasons: to obtain a biopsy specimen, as a prophylactic treatment, to determine the effectiveness of therapy, for palliation, or as an attempt at a cure. Reconstructive surgery also is associated with cancer treatment. A woman who has had a breast removed by mastectomy may have the breast reconstructed using tissue from the patient's abdomen, back, or buttocks to form the reconstructed breast that is completed with a saline-filled breast implant. Surgical removal of a malignant growth is the oldest method of treatment. It works very well for tumors that are easily accessible. Newer surgical procedures and techniques have significantly reduced the need for extensive surgical removal of adjacent tissues and structures. If there is no evidence of metastasis, some patients are good candidates for a simple removal of the tumor, termed a lumpectomy. Rarely can surgery alone cure or control cancer. This is considered a systemic disease, except for basal cell skin cancers. Radiation therapy uses high-energy radiation from gamma rays or ionizing radiation beams. As part of cancer treatment, RT is used to control or kill malignant cells, to prevent tumor reoccurrence, or to relieve symptoms of pain or discomfort. Radiation therapy can also be given by implanting a radioactive element or substance inside the patient, such as radioactive seeds implanted within the prostate to treat prostate cancer. Radiation therapy has been used before, during, and after chemotherapy in susceptible cancers. Radiation therapy has both short and long-term effects, depending on the area radiated. Ionizing radiation can have both an immediate and delayed effect on the malignant cells. When a cell is damaged in this way, it will not die until it attempts to divide and replicate itself. The rate at which a particular kind of cell undergoes mitosis will determine how quickly the effects of radiation will occur. The other factors considered are the sensitivity of the tumor to radiation, its location, and its size. Once calculated, the dose of ionizing radiation is fractionalized, meaning that it's divided over many days to weeks to deliver the optimal dosage with the least amount of effect to the normal tissues. External beam radiation or teletherapy and brachytherapy are two types of radiation delivery that can be used to treat cancer. Teletherapy is external. The source of the radiation is delivered to the outside body of the patient. Brachytherapy is internal. This is a sealed radiation source that is placed inside or next to the area requiring treatment. So the source of radiation is a radioactive element or substance that has been implanted or injected into the body to provide low doses in focused areas. The linear accelerator used for external radiation therapy produces extremely high energy X-ray and electron beam irradiation. This bombards the malignant cells and then destroys them. Because malignant cells divide at an abnormally high rate, they are more susceptible to destruction than normal cells. The use of stereotactic surgery is effective for small brain tumors. Depending on the dosage given, the patient may not need to receive further radiation. This method has proven beneficial for cancers of the head and neck, abdomen, pelvis, and extremities, and for patients with operable pancreatic cancer. Nursing care goals related to cancer radiation therapy would include helping the patient and family cope with the diagnosis of cancer and understanding the radiation treatment, and teaching the patient and family how to recognize and manage the expected side effects of the radiation. A lack of knowledge about the side effects of radiation and how to cope with them can greatly add to the anxiety and stress that a patient feels. Before the first treatment, the patient is told what therapeutic effects are anticipated, what it is like to have a treatment, and what to expect during the course of therapy. Someone should accompany the patient for initial treatments for emotional support. Assure the patient that the source of radiation is in the linear accelerator machine only. It is not possible to contaminate others when receiving this type of radiation therapy. The most common side effect of radiation therapy is changes to the skin. This is known as radiation dermatitis. These changes can range from redness to rash and peeling of the skin. Another common side effect of radiation is fatigue, thought to occur due to the lysis of tumor cells or the increased energy needed for repair of normal cells in the radiation path. In preparation for radiation therapy, the healthcare provider will outline the area to be exposed to radiation by marking it with indelible ink. The exposed area will need special care. Although skin damage is less now, the degree of reaction of the skin to radiation is individual, and it should be assessed daily, either by the patient or another knowledgeable person. The patient will feel less anxious when they know what to expect and how to perform their self-care at home. It is essential to provide verbal and written instructions to the patient and family. Patients should be taught to bring a small notebook to write down instructions if needed and to keep a list of all questions that they may have before their next visit, as well as to note any points in which they feel they need more information on. Radiation from radioactive elements has the same ionizing effect as that from linear accelerators. The only difference is the source of radiation. Internal radiation is known as brachytherapy. The substance is then eliminated from the body through body secretions, such as urine, feces, sweat, sputum, and vomit. To be effective, the radiation source must come into direct contact with the tumor tissue for a specified amount of time. Because the radiation source is within the patient, radiation is emitted for a period and can be a hazard to others. Nurses caring for patients who are receiving internal radiation need to take extra precautions. Once the source of radiation is completely eliminated from the body, the patient and body waste are no longer radioactive. As soon as an element becomes radioactive, it will begin to lose its characteristics of radioactivity. The rate at which it becomes less radioactive is called its half-life. This is the amount of time it takes for half of the radioactivity to dissipate. It is important that nurses caring for a patient who is receiving sealed or unsealed sources of radiation know the element used and its half-life, and the ways in which it might be eliminated from the body, in order to help keep themselves and their patients safe. Nurses caring for these patients are specially trained for this task and should follow their hospital policy. In general, the amount of radiation you might receive while caring for a patient being treated with internal radioactive elements will depend on three factors: the distance between you and the patient, the amount of time spent in actual proximity to the patient, and the degree of shielding that the body is provided. Doubling one's distance from a radioactive element will reduce the exposure to 1/4, and tripling the distance will reduce it to 1/9. The total time spent with the radioactive patient, should be less than 30 minutes per shift. Shielding from radiation exposure must take into account the type of rays being emitted. The denser the shielding material, the less the possibility of penetration by the rays, and the better the protection. Hospitals where sealed sources of radiation are implanted into the body tissues to treat malignancies usually have written policies and procedures to guide these personnel who are responsible for patient care. Chemotherapy treatment protocols have been established for most types of cancer. Protocols are based on scientific evidence of their effectiveness in treating the type of cancer that a patient has. Which treatment is chosen will depend on the type of cancer, if it has spread, and the health of the patient. Chemotherapy can be given before surgery to shrink a tumor or after surgery. Chemotherapy can also be given with other treatments such as immunotherapy. Chemotherapy drugs are referred to as anti-neoplastic agents. The overall goal of anti-neoplastic drugs is to decrease the number of malignant cells in a generalized malignancy, to reduce the size of a localized tumor, to relieve symptoms or prepare the patient for surgery, or to treat escaped cancer cells to prevent recurrence or metastasis. Anti-neoplastic drugs are cytotoxic. This means that they are poisonous to normal cells, and their damaging effects are not limited to only malignant cells. Drug combinations, known as combination chemotherapy, are used to treat certain types of cancers because different drugs are effective at different times in the growth and replication cycles of the tumor cell. This method will offer the best chance of killing the most malignant cells. Techniques of administration of anti-neoplastic agents would include IV, intraarterial, intraperitoneal, intraventricular, and intrathecal. Chemotherapy drug dosages are based on body surface area. This will consider height and weight of the patient. Chemotherapy drugs are classified as hazardous drugs and need careful handling in accordance with standards set by the Oncology Nursing Society and your institution's policies and procedures. Chemotherapy is to be administered only by RNs who have completed an approved chemotherapy program and have demonstrated competence in administering these agents. The LPN does not administer chemotherapy in the scope of their practice. However, responsibility for monitoring the patient during chemotherapy administration does rest with all nurses providing patient care. IV administration of chemotherapy is the most common route, and an implanted injection port may be used as a long-term access to administer chemotherapy drugs that will be given over several weeks or months. Remember, most of these drugs are tetragenic. This means they can cause birth defects, so handling of chemotherapy drugs should be avoided during pregnancy. Many anti-neoplastic drugs are vesicants. These can cause severe local injury if they infiltrate into surrounding tissues from the vein when they are administered. This is why we need to monitor the IV site closely throughout the entire infusion shift. If extravasation occurs, inform the RN, who should then follow the agency's policies and procedures and inform the healthcare provider as well as the pharmacy. Currently, a few chemotherapy drugs are available in an oral form to be taken by mouth. Oral anti-cancer drugs are just as toxic to the patient and to you or the person handling the drugs as are IV chemotherapy drugs. Oral chemotherapy drugs should not be crushed, split, or chewed. These drugs are considered a biohazard and must be disposed of according to recommendations by the pharmacist. Anti-neoplastic drugs have toxic effects that need to be assessed and monitored. Not all anti-neoplastic drugs will produce every toxic side effect, and the oncologist will plan therapy so that destruction of malignant cells can be maximized and toxicity minimized. The toxicity associated with chemotherapy is most evident in the cells of the body that have a short lifespan, and therefore need to continuously reproduce to provide the body with the normal cells it needs. These types of cells would include the blood cells, hair follicles, and epithelial cells of the mucous membranes lining the digestive tract. Patients can experience severe anemia, reduced immunity due to decreased white blood cells, thrombocytopenia that affects blood clotting, alopecia, mucositis, nausea, vomiting, or constipation or diarrhea. Certain hormones can cause hormone-sensitive tumors to grow more rapidly, so decreasing the level of the hormone can slow tumor growth or prevent recurrence. Hormone therapy, also known as hormonal or endocrine therapy, can be used alone or as an adjunct to other types of cancer therapy. Tamoxifen is a selective estrogen receptor modulator. It's an example of an oral drug that will produce metabolites that bind to the estrogen receptor on tumor cells. This then prevents tumor growth in women with breast cancer. Tamoxifen has been shown to be chemopreventative for women with a high risk of breast cancer, and both drugs will improve survival after breast cancer. Side effects of hormone therapy will depend on the type of hormone targeted. All patients taking estrogen or progestins are at an increased risk of VTE. Biologic response modifiers, or BRMs, are agents that manipulate the immune system in the hope of controlling or curing a malignancy with little or no toxic effect on normal cells. These agents will either stimulate or suppress immune activity. The BRMs include interferons, interleukins, colony-stimulating factor, monoclonal antibodies, vaccines, gene therapy, and nonspecific immunomodulating agents. They essentially make the immune system function better. BRMs will stimulate the immune system to recognize cancer cells and to institute action to destroy them. Some BRMs, such as CSF, will work by enhancing a quick recovery of the bone marrow after radiation or chemotherapy. CSF stimulates bone marrow to function more quickly. Two types of BRMs that are used to fight cancer are interleukins and interferons. Interleukins help the immune system recognize and destroy abnormal cells. Interferons slow cell division in cancer cells, stimulate natural killer cells, delay the appearance of oncogenes, and assist cancerous cells to revert to more normal cells. Interferons are used effectively against leukemia, melanoma, multiple myeloma, carcinoid tumors, and renal carcinoma. Both interleukins and interferons are very expensive to manufacture. Patients receiving high-dose BRM therapy may need to be in an ICU or on a monitored unit. Neurologic symptoms associated with BRMs can be concerning and would include severe depression, confusion, fatigue, somnolence, irritation or agitation, hallucinations, anxiety, and sleep problems. Other issues would include fever, chills, rigors, and flu-like symptoms. Monoclonal antibodies are manufactured using genetic engineering to make antibodies against certain cancer cells. MOABs will work by binding to antigens on the cell surface of the tumor, preventing the cancer cell from growing and dividing. Allergic reactions can occur in patients receiving monoclonal antibodies because of the incorporation of some non-human proteins. However, recently these antibodies have been humanized, reducing the risk for any allergic reactions. Nursing assessment is key for early recognition of a potentially life-threatening allergic reaction. Targeted therapies are a newer form of cancer treatment that blocks the growth and spread of cancer by interfering with the specific cellular growth pathways or molecules involved in the growth and reproduction of cancer cells. Targeting these signal pathways will block the activation of oncogenes and other factors in cancer cells to slow or stop cell division. Side effects common to most TKIs would include nausea, vomiting, fluid retention, electrolyte imbalances, and bone marrow suppression. Bone marrow transplantation is mainly used to correct the severe bone marrow damage caused by chemotherapy or radiation. Sometimes total body irradiation is used to treat a hematopoietic cancer, such as leukemia or Hodgkin's disease. Irradiation of this sort will totally incapacitate the body's bone marrow, and the patient would die if the blood cells could not again be manufactured. Stem cells may be transplanted to overcome these devastating effects of chemotherapy or total body irradiation before BMT. The problems that can be experienced by cancer patients are complex and depend on both the location and the type of cancer, as well as the therapy used to treat it. Many cancer patients experience an alteration in taste that can be due to cancer progression or cancer treatment. Commonly, the first thing noticed is that red meat does not taste good. Anorexia is often associated with changes in taste and mucositis that can cause the patient great difficulty in eating and drinking. A patient with anorexia can experience a significant weight loss and may suffer from severe malnutrition. Patients with cancer should be taught to increase their protein intake to 1.5 grams per kilogram of weight per day. The patient should be encouraged to eat small, frequent meals and add calorie-dense snacks. It is important to note that older people with cancer are more likely to suffer malnutrition, with about 90% experiencing weight loss during chemotherapy. Patients undergoing chemotherapy may experience mucositis or sores. These can occur in the mouth and then extend throughout the GI tract. Stomatitis is an inflammatory reaction in the mouth. Both mucositis and stomatitis can result in pain and interfere with eating and swallowing. For patients receiving chemotherapy, oral cryotherapy can be used for the prevention of mucositis. You should perform an assessment of the mouth and report any abnormal findings to the RN. Toothbrushing should be followed by a thorough mouth rinsing with plain water or saline. Rinsing the mouth is encouraged after meals and at bedtime. Teach patients to avoid mouthwashes that contain alcohol, as they can dry and irritate the oral mucosa. Relief of the mouth pain of mucositis or stomatitis can be provided by special topical compounds that are then swished and spit. The patient is instructed not to swallow these solutions, and they should avoid spicy foods, alcohol, and tobacco while undergoing treatment. Patients are encouraged to drink water as often as possible to help alleviate the discomfort and dryness of the mouth and tongue. Artificial saliva can combat mouth dryness in a different way and will also help keep the mucous membrane soft and moist. It will help buffer the acidity in the mouth and thus reduce irritation to the oral mucosa. It can be found in a local pharmacy or obtained from most online drugstores. Many cancer drugs are emetogenic. This means they induce vomiting. Chemotherapy-induced nausea and vomiting can persist for 1 to 2 days after chemotherapy is given. Antiemetics should be given before the nausea and vomiting begin. Nursing priority is to ensure adequate control of CI/NV. Teach the patients to continue antiemetic drugs even when CI/NV appears controlled. When the patient stops taking the drugs, teach them to start retaking the drugs at the first sign of nausea to prevent it from becoming uncontrollable. Many chemotherapy drugs and newer targeted therapies cause diarrhea because they affect the cells of the intestinal mucosa, causing inflammation. Radiation to the GI tract or pelvis can also result in diarrhea. Loperamide is recommended for uncomplicated mild to moderate diarrhea, and octreotide is recommended for severe diarrhea. Teach the patient to avoid high-fiber foods that would encourage rapid evacuation from the bowel, and to add low-fiber foods such as bananas and cheese to the diet. Cheese and crackers are a great addition. You must monitor the patient for signs of dehydration and electrolyte imbalance. Increasing fluids, adding fiber to the diet, administering stool softeners and fiber laxatives, exercise, and monitoring vigilantly for the beginning signs of constipation are the usual measures taken. Suppositories or enemas can be necessary. Chemotherapy-induced peripheral neuropathy is the loss of sensation or motor function of the peripheral nerves from certain chemotherapy agents. The degree of CIPN is related to the dosage of nerve-damaging drugs. Higher dosages will lead to greater neuropathy. CIPN is a long-term consequence and can be permanent in some adults. The priority for nursing care for patients experiencing CIPN is teaching them to prevent injury. Falls are more likely due to changes in gait and balance and decreased sensation in the feet. One of the most significant and potentially life-threatening side effects of chemotherapy is suppression of the bone marrow. Most of the infections arise from overgrowth of the patient's own normal organisms. The risk for bone marrow suppression is related to the dose of chemotherapy received. Bone marrow suppression is the main reason why the dose of chemotherapy may be reduced or treatment delayed until the bone marrow recovers. The white blood cell count is closely monitored. A count of less than 3,000 would indicate neutropenia. Filgrastim or sargomastrum can be given to raise the neutrophil and white blood cell counts. Often, administration of these injectable agents should be done before the white blood cell count drops too low. If the neutrophil count is below 500, follow policies and procedures for protective isolation to prevent infection. The decreased red blood cell count and anemia resulting from chemotherapy will place an increased workload on the heart and lungs as these organs attempt to oxygenate the body appropriately. The most common symptom from anemia is fatigue. When the platelet count reaches a low of 50,000, any small injury can lead to an episode of prolonged bleeding. At 20,000, spontaneous bleeding that is difficult to control may occur. Teach patients to weigh themselves daily and keep a record. Remind them to immediately report sudden weight gain or dyspnea to the healthcare provider. The patient must be handled gently. Using a lift sheet will help in turning and repositioning the patient. When a blood sample or IV access is needed, the smallest gauge needle possible for the task should be used. Once a needle is removed, apply pressure to the site for 5 to 10 minutes until all bleeding stops. On page 174 in the blue patient teaching box, we can see some cancer treatment and infection prevention strategies. Cancer-related fatigue is distressing, and a persistent feeling of tiredness or exhaustion from cancer or cancer treatment will occur. It is estimated that 25% to 99% of patients with cancer have fatigue. The Oncology Nursing Society proposed increased physical activity or exercise as a first-line treatment for CRF. There is not enough evidence to support the use of medications for the treatment of CRF. Non-pharmacologic recommendations for the treatment of CRF would include increasing physical activity, minimizing bed rest and prolonged naps, maintaining a good balance between energy and activity, minimizing emotional distress, maintaining activities of daily living, and prioritizing activities. Using relaxation techniques during cancer treatment can be helpful in reducing CRF, but it is less effective once the treatment is completed. In addition, maintaining a good nutritional status with high protein intake can help keep up energy levels. Fluid should be increased to 2 to 3 liters per day on day 3 of chemotherapy, unless contraindicated, to help flush waste materials from the body. Chemotherapy-induced alopecia is a common and distressing effect of many types of chemotherapy drugs. Alopecia resulting from chemotherapy is mostly temporary. Radiation therapy to the head almost always results in permanent hair loss. Hair regrowth begins about 1 month after chemotherapy ends. The patient should be informed that the new hair may differ in color or texture than their original hair. Before hair loss occurs, the patient should also be counseled to choose a wig or head cover to wear until their hair regrows. Hair loss will usually begin by the second chemotherapy treatment. Whatever your patient decides, we must support their decision. Cancer pain can come from disease as it advances and invades other organs, bones, and soft tissue. Pain from cancer or its treatment is very common. It is estimated that as many as 75% of patients with cancer will report pain as a frequent symptom following cancer treatments. Cancer pain will also occur with other symptoms and can be made worse by other symptoms such as sleepiness, depression, anxiety, and significantly reducing the patient's quality of life. Recently, the opioid crisis in the United States has brought attention to the use of these medications in the control of cancer pain. Currently, there is little evidence to help nurses understand the risk factors and extent of opioid abuse in the cancer patient population. Complementary and alternative therapies, such as acupuncture, can supplement medications for cancer pain, but they have limited effectiveness when used alone. Adjunctive medications used alongside analgesics will help control cancer pain. This can include steroids, antidepressants, anti-seizure drugs. Pain should be reassessed 15 to 30 minutes after parenteral drug administration and 1 hour after oral drugs are given. Medication doses should be scheduled regularly and around the clock to maintain a therapeutic drug level and prevent pain reoccurrence. Since opioids are used frequently, a bowel program should be started using stool softeners and laxatives in order to prevent severe constipation. The main factor for controlling cancer pain is to continue to seek a combination of different treatments until the pain is under control. A cancer diagnosis brings with it feelings of fear and anxiety, and in a time of great stress and uncertainty. Understanding the disease, treatment options, and what will be experienced during each type of treatment can greatly help to decrease the fear experienced by patients and their families. Knowing what to expect will help patients and families feel less fearful about the experience of surgery, chemotherapy, and a loss of control over their lives. An assessment of the patient and family's usual coping techniques is important in formulating the overall plan of care. You must consider psychosocial and spiritual care when working with a patient with cancer because the disease will affect every aspect of their life in some way. Care of the cancer patient is a collaborative process and will involve many members of the healthcare team. Encourage the patient and the patient's partner to discuss concerns related to sexuality that may come from cancers of the breast, prostate, or reproductive organs. If sexual function has been altered by surgery or treatment, help the patient find other means of sexual expression and gratification. Referral to a social worker may be needed to coordinate resources for treatment and care assistance. An oncologic emergency is a cancer-related disorder that requires emergency medical or surgical treatment. Oncologic emergencies are classified as being metabolic, hematologic, or structural. There are 6 major oncologic emergencies. This includes tumor lysis syndrome, hypercalcemia of malignancy, disseminated intravascular coagulation, neutropenia, spinal cord compression, and superior vena cava syndrome. When these emergencies occur, immediate action must be taken to prevent severe injury or death. Although an increasing number of cancer patients are surviving their disease through cure or control, cancer is still the second leading cause of death in the United States. Nurses working with cancer patients need to understand the process of death and dying as well as grief. Dr. Kubler-Ross suggested that people go through 5 predictable stages as they learn to adapt to the processes of loss or impending death. Not everyone will go through all of the stages, and people will not go through the stages in the same order. These stages can apply to the grieving process when a body function or body part is lost, a loved one dies, or one's own death is approaching. Almost all dying patients and families face varying levels of fear. One of the most helpful things that you can do is be there for your patient and encourage them to share their feelings while expressing caring. In the same way, when a patient displays behavior that is upsetting to the family, you can explain the behaviors to the family as normal for those going through the stages of grief and dying. When the nurses care for dying patients regularly, they cannot help but reflect on their own mortality. It is important to review your own beliefs about death and dying and then reaffirm those beliefs. Very often, spiritual matters are considered whether they are connected to an organized religion or not. Find out from your patient what they feel is important. Nurses need to support this area that is meaningful to patients. Take a periodic inventory of your ability to provide care without burnout. If you come to the point where you can only provide care in a detached and distant manner, you can no longer be supportive, compassionate, and understanding. When this happens, it is time to take a break or move on and let others provide care for the dying patient. Palliative care is delivered by a multidisciplinary team of healthcare providers. The goal of palliative care is to provide relief of symptoms with the goal of improving the quality of life. Palliative care can be provided at home or in hospitals, clinics, or skilled care facilities. Patients who have a shortened life expectancy of 6 months or less should be referred to hospice care. Hospice care implies that the treatment of the illness has stopped, and the focus is on comfort care, symptom relief, and emotional and spiritual care until the end of life. You can prepare the family and the patient by helping them anticipate the death to come, giving them guidance about physical changes, symptoms, complications that could arise, and decisions about possible hospice care. There are 2 stages of dying. In the preactive phase, patients know that they're dying and they exhibit this knowledge by withdrawing from social activities or attempting to put their affairs in order. This phase can take weeks or months. When patients enter the active phase of dying, this occurs during the final 2 to 3 days. They will exhibit specific signs and breathing patterns and other body functions that will indicate death is imminent. A dying patient naturally and gradually reduces their fluid intake. You should be ready to educate the patient about this process during the dying phase. Forcing the patient to eat or drink is discouraged. Many times the course is for the patient to choose what to take and also to be allowed to refuse further nourishment. This is called patient-endorsed intake. Many expected symptoms are related to metabolic changes at the end of life. Because comfort is the goal of palliative care, administering oral or sublingual medications is the preferred choice. Pain control at the end of life is an important goal, so nurses should work with the healthcare provider to give medications as ordered and notify the provider if pain is not adequately controlled. When patients are near death and able to respond, they sometimes may feel as if they cannot get enough air. Place the patient in Fowler's position, adjust the air temperature for the patient's comfort, and give medications such as bronchodilators as ordered. Oxygen via nasal cannula can be helpful as well. Morphine is often given to ease breathing. Noisy breathing can be heard at the end of life when patients can no longer clear their throats of normal secretions. Family members are often alarmed by this. Again, morphine can help ease this symptom, and scopolamine or atropine are drugs that are known to reduce secretions, can be used to quiet the patient and quiet the breathing. Dying patients may experience hallucinations and/or altered mental status. Make sure the patient is in a comfortable position and that pain is controlled. Explain delirium with the patient's family and encourage the family to talk to the patient in quiet tones while remaining calm.